Maverick Physical Therapy. Welcome to a little kinetic linking episode on the biomechanics of the golf swing to transition us to TZ, kind of through TZ1 to give us a good explode. As we've talked about before with regards to our transformational zones, biomechanics and movement in general, is that movement is a direct response to how well the body loads. It's like a slingshot, a rubber band, a bouncy ball. It's like the ball loading and mushing on the face of the club head at impact before the ball is slung shot out of the cannon. A few things that we're going to take a look at, such as with the right-handed golfer, are kind of the biomechanics of that swing and where it originates and how it continues to kind of transition and load. So I'm going to use my little pelvis friend right there and spine model, and then kind of our pelvis and femur model right there as well. But as we approach the ball and set up shop, as we start to transition back into our backswing, we have a three-dimensional load taking place throughout the entire body. It starts for the right-handed golfer at the left foot in the ankle. As the hands start to transition on back, and kind of that frontal plane, kind of transverse plane to give us that type 1 out of sync, the left heel, the calcaneus, starts to evert. It everts so that it can unlock kind of that mid-tarsal joint, and so that we can get some medial rotation of the leg. The leg needs to rotate in towards the midline of the body, which then the femur will follow, which then the pelvis will follow. So we get internal rotation at the left hip initially, which then transitions to external rotation as the pelvis goes further than what the femur does. So we get this bottom up load that affects top down the right hip, the right foot and ankle, knee, due to the loading of the upper extremity, but due to the left side of the pelvis, that ilium loading the right hip. So this loading transitions to the right side, which from the top down we have the pelvis rotating to the right faster than what the femur is to give us internal rotation of the right butt. We have the pelvis, due to that left knee kind of giving us the relative abduction and driving kind of down and into the right. We get a collapse of the pelvis on the left side, so that left kind of side bend there, which is going to couple with kind of our posterior kind of translation to load the right butt and hip. We also get down then to the knee. We also get from the right hip internal rotation of the right knee, due to the femur rotating to the right, but relatively speaking, tibia not rotating quite as fast. We'll then get some relative inversion, some inverting of the calcaneus in the frontal plane. So we get this big winding like effect, and from the top down, further yet, not just top down meaning pelvis, but upper extremity here, we get this frontal plane load that's going to act too with the arms overhead at the apex of the backswing. That's going to act to help load the right butt and hip in that frontal plane. But then we also, due to it loading kind of the thoracic spine and that scapulothoracic joint, we get the extension in the thoracic spine coupled with our right rotation and our left side bend. The right rotation is going to help load the internal rotation at the right butt and hip. Commonalities of things that you'll see on a golf course are a lot of gross distortion patterns and imbalances stemming from poor loadability of the left foot and ankle and left hip loadability, to poor loadability then of the right hip and the right foot and ankle, and poor upper extremity mobility, thoracic spine mobility three-dimensionally kind of coupled, as well as scapulothoracic joint, scapular mobility, shoulder mobility. So a combination of a lot of different things. So what we're doing here is stating that there's some biomechanical guidelines and truths that have to take place in order to hit a golf ball successfully well, consistently and efficiently well. And so with that, in order to give us that kind of that good slingshot approach, this has to occur from, this loadability has to occur from the bottom up and then also the top down. So model wise right here, let's look at this pelvis first. We have a little internal rotation created at the left hip due to the left knee driving down and in. So the femur ends up rotating to the right. The pelvis rotates to the right, but ultimately then the pelvis continues to go as the femur slows down, giving us external rotation. We get internal rotation of the right hip here. As the pelvis and as our arms are transitioning into our backswing, we have the pelvis dropping down as well as kind of transitioning or translating backwards, but then the pelvis also anteriorly rotates. It has to tilt forward. So that anterior rotation is coupled with the translation to the right, which will then give us good extension, help give us some good extension in the thoracic spine as well. Pelvis model, if you remember the segments that we went through in terms of rotation and translation, we have in the transverse plane we get this mushing down translation here with this right rotation of the pelvis. And that's our z-axis. Our y-axis, we get this anterior rotation of the pelvis as we're transitioning to TZ1. And again, we train, we treat, we assess in these transformational zones because that's where injury occurs, but that's where the sequencing of loadability to therefore give us movement occurs. We get this anterior rotation of the pelvis, which is coupled with frontal plane translation. I'm just doing a little golf video, buddy. You want to show everybody how we can hit some golf balls? Go get your golf balls and your golf clubs and we'll go ahead and hit. We then, in the frontal plane, this x-axis, we get this rotation to the left of the pelvis, this left side bend of the innominate on the left side, which then, again, coordinates with this posterior translation. Matt, go get your golf balls. Your golf balls are right here. Go get your golf balls and we'll show everybody how we can play golf. So the sequencing of all this has to occur to prevent any overloading of what we typically see in the clinic wise, some medial epicondylitis as well as some lateral epicondylitis, which we see a lot more of. Oddly enough, they call the lateral epicondylitis tennis elbow and a medial golfer's elbow. But we get the system that will break down. We'll get these herniated discs, these protrusions, these bulging discs due to not being able to control the three-dimensional rotation and loadability throughout the feet and the ankles, the hips, and the trunk. We'll get compensation that will, L-spine-wise, a lot of times we'll see a lot of instabilities due to the hips and the thoracic spine not moving. So we'll get knees chewed up, we'll get hips chewed up, we'll get low back chewed up, we'll get shoulders kind of chewed on up. So what we're going to do in some of our future episodes is take a look at how we can further provide an environment and position ourselves to load our feet and our ankles and our hips and our trunk all in combination with each other to provide us a better golf swing, a more efficient golf swing, a more consistent golf swing, to enable us to continue to do what we love doing. We're going to go through some very unconventional things that on the range you're going to have a lot of people looking at you in some very, very strange, some very unique ways. The golf swing starts from the left foot and ankle, works its way on up, bottom up driver, becomes a top down driver to the right side as we transition into our backswing. As we transition our backswing, this type 1 kind of out of sync, kind of loading right here with this adduction of the right hip with this slight kind of a deduction at the right knee, with some of this slight kind of inverting motion going on at the subtalar joint and the calcaneus, to then allow us from the bottom up, after we load on up, as we kind of follow suit here and get to the top, to explode out of it. That right foot and ankle are going to start to evert before it transitions to inversion and plantar flexion. And this unwinding, which will then start from the bottom up on the right side, and as we start to transition out of that, starts from the bottom up. We'll continue then to load that right hip and internal rotation, as the pelvis, due to the top-down driver of the upper extremity, is still loading the right hip. The femur will start to rotate towards the ball and towards our target, giving us more internal rotation and more loadability and swing. When we talked about proprioceptors before, and the slingshot that we're catapulting, those little mechanoreceptors are sensitive to stretch, compression, and tension. So three-dimensional, we're getting some tissue that's unloading while it's still continuing to load, to keep us on track, to provide more and better feedback, to provide more accuracy, precision, and power. So as we get to the top and start to unload right here, we're still getting this top-down load from upper extremity, the trunk, the T-spine scapulothoracic joint, that's going to continue to load the hips, so that as we transition from that backswing on through to almost kind of a TZ1 kind of B position right here, we're still getting kind of this, type 1 kind of out of sync loading of kind of the trunk as we transition down in through and make contact with the ball, to give us external rotation and extension of the back hip with the abduction, with the type 1 out of sync. Transformational Zone 1, the biomechanics, the functional biomechanics of the golf swing. An applied functional scientist knows them better than anybody. We have some great episodes coming later with regard to how we can make and transition you into this daily activity regimen to help make you more consistent.